In this video series, clinical experts and WTR advisors discuss modern approaches to treating specific tumor types. Joining us for this video is Dr. Maria Cabanillas, WTR Clinical and Oncologic Endocrinology Advisor.
Hello, my name is Maria Cabanillas, and I'm going to share with you a video about anaplastic thyroid cancer for patients who have BRAF V600E mutated disease. The staging for anaplastic thyroid cancer is quite simple. All patients have stage 4 disease because they have a high risk of dying from their cancer. It's further divided into stage 4A, 4B, and 4C. 4A disease are tumors that are resectable, and these should undergo surgery. Stage 4B are tumors that have escaped the thyroid gland or have moved into the regional lymph nodes. And stage 4C patients are those that have metastatic disease, and that's about 50% of patients at presentation. So today we're going to talk specifically about stage 4B and C patients who have a BRAF V600E mutation, and this comprises about 40% of patients. The initial workup should include full staging, and that you can see in this box here. It should include an MRI of the brain. We should perform mutations and fusions and a rapid V600E mutation test. This can be done with immunohistochemistry, seen down here, or with rapid PCR. We should determine the airway stability, the resectability of the tumor, confirm the diagnosis with our pathologist, and then have a goals of care discussion with the patient once you know the prognosis. So the management of these patients starts with induction, and within induction, we have rapid cytoreduction and management of resistant clones. Now, we need rapid cytoreduction because these tumors cause a lot of symptoms. We really want to get that tumor volume down. And then we need to follow it with some management of the resistant clones that are going to emerge. Now, in the United States, we have BRAF MEK inhibitors available to us, which we use for rapid cytoreduction, and then the checkpoint inhibitor immunotherapy, which we use for resistant clones. We then follow that with consolidation, and that usually includes surgery, could also include radiation, and then a maintenance period where we give the initial drugs for a long period of time. We don't know really how long that is right now, but these patients do need to continue on systemic therapy. Now, let's start with rapid cytoreduction. Can be, again, as I said, with a BRAF MEK inhibitor, but this, when not available, could be substituted with lenvatinib. And when neither of it are available, patients with 4B disease could undergo full dose radiation, and patients with 4C disease could undergo a short course of radiation so that chemotherapy can then be started. This is an example of patients who underwent treatment with dabrafenib and had very rapid responses. So this is a gentleman here with disease metastatic to the skin, and you see 5 weeks later on dabrafenib, he has had a very nice response. On the right is a patient who refused a tracheostomy, and then after 1 month of treatment, you see there is no tracheostomy because she was put on dabrafenib and had a very nice response that opened up her airway. So dabrafenib was approved for BRAF mutated ATC in the United States based on this study, which showed a response rate of 56% and a median overall survival of 14 and a half months, and median progression-free survival was 6.7 months. Those are very good results, and many people ask, well, why continue to add more therapy? And the reason is that acquired resistance almost universally emerges in patients who are treated with kinase inhibitors. And therefore, we need to anticipate that this is going to happen. So here's an example of a patient who had a scalp metastasis, goes on to dabrafenib, does very, very well, and then that metastasis starts to return. The initial mutations consisted of BRAF, ATM, and MCL1. And then we removed this scalp tumor, and what we see is the BRAF continues to be there, but also, as well as the ATM, but also we see AKT2, KRAS, and TERT have emerged. Induction part 2 is the management of resistant clones, and we do this at our institution with immunotherapy. This is a retrospective study that we performed at our institution, and we looked at patients who were treated with just first-line dabrafenib versus first-line dabrafenib pembrolizumab. And we find that the patients who had the triplet therapy the dabrafenib plus pembrolizumab had a median overall survival of 17 months versus those who had only dabrafenib but a median overall survival of 9 months. And this was statistically significant. We also did a prospective study where we had similar combinations of drug. This was bemorafenib, cobimetinib, and atezolizumab in this first cohort here that you see to the left. And the median overall survival was very long in this group when you combined it with the immunotherapy. Let's move on to consolidation. So once we have a very nice response in induction, then we can move on to consolidation. So you want to maintain that response. And the way that we do this at my institution is that we take out the thyroid gland or the neck disease after a good response with dabrafenib and pembrolizumab. And this is a phase 2 trial, multi-center, that we did and presented at ASCO 2025. It followed really the same schema that I just showed you with an induction period, a consolidation period, and a maintenance period. Just to summarize, the primary endpoint was an R0, R1 resection, and we compared that to a 5% resection rate as a historical control. Also, overall survival, which was compared to a historical median of 9.6 months. This was designed prior to the dabrafenib study that I previously showed you. The results are that 74% of patients underwent an R0, R1 resection. The median overall survival of the entire group was 18 months, and both of these were statistically significant. So, what do we do when BRAF targeted therapy and immunotherapy are not available? Stage 4B patients should be treated per the management of non BRAF mutated ATC, and that includes upfront chemotherapy and radiation, or starting with surgery and then giving chemoradiation. For stage 4C patients, it's a little bit trickier, but we can do lenvatinib plus or minus pembrolizumab. We can give other cytotoxic chemotherapies. We can also try carboplatin pemetrexed, which has been shown to have some efficacy in very advanced patients at salvage therapy. So I thank you for your attention today.